Okay, so welcome everybody. Good morning for some, good afternoon, and good evening, depending where you are in the world. My name is Carlos Prada. I will be moderating this session, which is brought to you by Harvard Global Orthopedics Collaborative and Zona Global. This is our last of four webinars on complex upper extremity trauma, and today we will be focusing on chronic elbow dislocations. And we have an awesome lineup of faculties and case presenters, which I have the pleasure to introduce to you soon. The agenda of the four sessions, you can see it here. All these sessions are recorded, and for those of you who are signed up, you have access to the pre-recorded sessions, the articles to prepare those sessions, and all the educational videos. So please feel free to check them out in the YouTube channel of Harvard Global Orthopedics. Today is, you can see there, our chronic elbow dislocation day. When you're using Zoom, you can activate your captions and follow the conversation in the language you prefer. We have checked them out, at least in Spanish, French, and English, and they are working well for most people. So we welcome you to do it so you can follow easier in case English is not your native language. Or you don't feel comfortable with it. And if you want to engage in the conversation, please feel free to either raise your hand in the Zoom functionality and we can call you and do your questions. But also, if you don't feel comfortable doing that, you can prefer using the chat feature or the Q&A section Zoom to send your questions. We will be doing the best we can to try to answer all the questions during the webinar, okay? The objectives of these webinars are to improve our knowledge of complex upper extremity trauma principles, to foster international discussion. We have a great faculty lineup from different continents, and to try to improve the orthopedic trauma care delivery, and to motivate and support younger surgeons in training or in early practice in low and middle income countries. And try to adapt this surgical and treatment principles to our realities of practice, which can be very diverse. The moderators of these sessions has been Dr. Kiran Agarwal Harding, who is working at Beth Israel Deaconess Medical Center, Harvard Medical Institute in Boston, and myself. I'm from Chile. I'm a hand, wrist, and elbow surgeon from Chile. This is the big team that makes everything possible as well. They are very supportive and they run all the things needed to get this conference done, and all the pre-recorded sessions and surveys and everything. So a big thank you to all of you. You do a fantastic job, and this wouldn't be possible without you guys. Today, I will introduce you to our case presenters. We have Dr. Shoaib from the Hand and Upper Limb Center in Combined Hospital in Lahore. Dr. Duane Anderson from Soto Christian Hospital in Soto, Ethiopia. We have Dr. Aida Garcia from Universidad Militar de Nueva Granada, Bogotá, Colombia. We have Dr. Carl Harper from Harvard Medical School in Beth Israel Deaconess Medical Center in Boston, United States. We also have with us Dr. Briscoe from Mayo Clinic in United States, and Dr. Rick Papandrea from the Medical College of Wisconsin in United States as well. It is our pleasure to have this awesome panel today. So our agenda today will start with a case presentation by Dr. Duane Anderson. We did a small change. We fixed a couple of things with the second case presentation. So after that, we will discuss some aspects related with the cases. And we will have some closing remarks in charge by Dr. Kiran Agarwal.
So, Carlos, it looks like Shoaib has his screen share working. So I think why don't we stick to the
Yeah,
plan?
perfect. Okay, so we will keep the initial agenda then, and we will start with Dr. Shoaib Javaid case. Okay, so without further ado, Dr. Shoaib Javaid, please, I will stop sharing my screen and we will start with your case.
Okay. Can you hear?
Yes, we can hear you and we can see your screen.
Okay.
Oh, Dr. Shoaib, we lost your screen share for some reason. There it is. Great. We can see the slides perfectly now. Go ahead.
Can you hear me now?
Yep, we can hear you now.
Yeah. Loud and clear.
Okay, so thank you very much and sorry for all this problem. My name is Dr. Shoaib Javaid. I'm a hand and upper limb surgeon from Combined Military Hospital, Lahore, Pakistan. So today I'd like to present a case. It's a 22 years old male who is right hand dominant with 6-month-old history of trauma to his left elbow. He was treated by a local bone setter by by casting his, splinting his arm elbow in the straight extended position. Now, when he presented to me, he was unable to move his elbow and his elbow was fixed in extension and he had a painful elbow. On examination, he had a deformed elbow joint compared to the contralateral side. There was no scar mark on the elbow. The arc of motion in flexion extension was 0 to 10 degrees. Pronosupination was nil and his neurovascular status was intact. His x-rays were done and this was his images. You can see it's a dislocated elbow joint. These were his CT scan. You can see that the humerus is anteriorly dislocated and the ulna goes posteriorly. So we never had any experience of dealing with this such cases. I saw one of my senior surgeons, he did that with the VY lengthening of the triceps, but that patient had a very poor result. So I started looking for, options, what to do. I came across this video on Vumedi and I watched it many times. And then I read this paper which I got to know from the same video. And, and these photos helped me a lot. I thank Dr. Duane Anderson for, coming up with this great technique. I made the same approach. I followed the same principles that he described in his video, and I was able to reduce the elbow within 88 to 90 minutes. And I was very happy because this was my first case. In this short video, you can see that I did the dual technique, the lateral and the medial approach. And I made the humerus naked, brought it out. You can see the lateral side. I made 2 thick flaps, anterior and posterior. This is the medial side. This is the nerve, you can see. And this is his medial epicondyle. You can see that after 90 minutes, I was able to reduce the elbow and the elbow joint was perfectly moving. Here I have not manipulated the elbow yet. And you can see that the ulno-humeral relation has been maintained, medial epicondyle, lateral epicondyle, and olecranon, and this is the movement. This is the fibrous tissue that was removed from the joint, you can see. And this is how I closed the elbow. This was again from the same paper, the same video. I took these and I put the ulnar nerve on the bone. I did not anteriorly transposed it over the muscle. In the subcutaneous plane, I put it on the bone and closed it. This is his x-rays at 2 weeks. This is his x-rays at 8 weeks post-op. And I can see a little bit of the heterotopic ossification that has come. This is his latest photographs. And you see, this is his latest to me yesterday at 8 weeks. He can move it. He's very happy. He has a stable, painless elbow, and he can bring the hand to his mouth. So he runs a business where he's already started working within 6 weeks. He's back to his normal life. And all thanks to Dr. Duane Anderson that he came up with this technique, and I was able to help this patient so much. Thank you. Thank you
all. Thank you, Dr. Javaid. That's a great case and great result in a very challenging situation, like the cases we will be seeing today, chronic elbow dislocations. You mentioned that you were using Dr. Anderson's technique, which is part of this this conference pre-recorded lectures and suggested material to basically review. So this was, as far I understand, your first case where you deal with this problem. What was your, like, can you tell me which was the main challenge? How challenging was it? What was the step that you struggled the most? You could share that with us, will be great. And then I will start asking some questions to our faculties as well.
So I prepared for this case very well. I saw that video many times, and I had written the plan on a paper and pasted in the theater, and I had revised it multiple times. So I was following all those principles that do not create a lot of flaps, just create an anterior and posterior flap. Reach to the bone, stay with the bone, remove the fibrous tissue, protect the cartilage that is available, and there is a lot of scar tissue over the cartilage. I removed that very carefully. I did not damage it, and I had no experience about it, but believe me, magically, when I made the humerus naked from both the medial and the lateral sides, I was easily able to reduce it. It appeared that like it's nothing. But previously, when the similar case was done with a posterior approach, with the triceps lengthening, it was very tough for us to reach there. And this was very easy. I think it's a great technique.
Could I ask a question? Do you mind, Carlos, if I just jump in? So, Dr. Shoaib, did you have to do anything with the triceps in this case? Because he was fronted in complete extension and had almost no motion. So did you have to do any lengthening? I know that in the video that Duane shared on VuMedi, he talks about doing lengthening, either fractional lengthening or, also the VY is being described. Did you have to do that in this case or no?
No, I didn't have to do that. I just reduced and manipulated it, just like a manipulation under anesthesia. Slowly, gradually, I manipulated it, and the hand touched the shoulder, and I stopped there. I thought it might not just break beyond that. The bone might not just fracture. So I stopped there. Mm-hmm. I was able to gain good about 140 to 150, degrees of flexion.
Wow, that's great.
With just close manipulation.
Duane, how often do you have to do a triceps lengthening in your cases?
What do you think, Ebenezer? Almost every time?
Well, no, nothing. One.
You haven't had to lengthen it? Get a needle in it?
Just one, yeah,
just the needle. And I would say it's 75%. So I guess maybe it's genetic. Or we have our patients come with a lot more HO. Maybe that's part of it. But I would say it's very commonly necessary to fractionally lengthen it. I like your term, Kiran. I use the word barbitage, but that sounds kind of barbaric.
And Dr. Anderson, I have a question for you as well. So you said that 75% of times you do this fractional lengthening with the needle. Would you say that you have encountered something that is a predictor for that, or for the cases identifying those 25% that will not? Is it associated at all with the time of the chronic dislocation, with the age of the patient group that you have encountered this chronic elbow dislocation, the amount of HO, for example, in the X-rays, in the pre-op X-rays? Is anything that you have seen on that end?
I haven't thought about that in terms of, am I going to anticipate it? I have one negative experience, and that is if you really go like this, you can get a hematoma. So I would recommend gently doing it. Don't be violent, and try to get to 90 degrees. I'm going to address this issue in the talk that I have. So those are the points that I'd like to make initially. Yeah.
Before we go, I think we're getting a couple of comments in the chat. Dr. Shoaib, do you mind just pulling up your PowerPoint again and pulling up your pre-op X-ray? Because I think some of our participants would like to take a look at that. Just what we're discussing, I think that would be helpful. And then I think we have a question from Matthews Mangondo. Matthews, would you like to unmute and ask your question?
Can you see my screen?
Yeah, we can. Thank you for that. That's very helpful.
So,
Dr. Shoaib, how difficult was it to dissect out the ulnar nerve? Was it encased in a lot of scar tissue?
If I noticed that if we go, proximal to the elbow joint, if we try to find it a little proximal to the elbow joint around the intermuscular septum, then we are easily able to identify it without any problem, and then go towards the elbow from proximal to distal. If we dissect it, it makes it quite easy.
Yeah, I teach all of my residents to do exactly that, like start proximal at the edge of the medial edge of the triceps and then dissect down. That's very good when you don't know where the anatomy is. It's all distorted. So Dr. Anderson, Duane in his lecture talks a little bit about the ulnar nerve being short and needing to put it in that submuscular position so that there's enough length to really be able to flex the elbow. Is that something that you experienced here? Did the ulnar nerve seem like it had shortened over time? Shoaib, you there?
Did you ask me?
Oh, there you are. Yeah, we can hear you now.
Yeah. Did you ask me anything?
Yeah, I was asking
hear you
about the ulnar nerve. Did the ulnar nerve seem short? Because I know that that's something that's described by Duane in his lecture video.
That did seem short. That did seem short. That is the reason I put it anteriorly, anterior to the bone underneath the musculature.
Great, excellent. Sorry, there's also a question from the chat asking about how you treat this patient post-op. Like, when you were testing and ranging him intraop, did it seem fairly stable to you, or after you repair the anterior and the posterior sleeves, medially and lateral, and you basically reattach the pronator and the flexor pronator and masses and the ligaments into the epicondyle? Did it seem stable enough that you allow them to move quite fairly quickly, or do you put them on a splint, or for how long? What was your post-operative management?
Yeah, I because I was doing this as my first case, so I was scared of making him to move after 3 days. So I put him in back slab for 2 weeks. I thought once his stitches are out, and then I will start moving. So I allowed him to move after 14 days, but I allowed him only to go for flexion and not the extension. I applied an extension blocking kind of backslap. So after 4 weeks, I allowed him all the movements, and he was doing excellent until 6 weeks when his movements, started reducing. And then at 8 weeks, when I got his X-rays, I saw the heterotopic ossification. It was there. I believe it. This is what is restricting him. And now I asked him yesterday to start lifting the bucket of water, just what Dr. Duane described. So he said, when I carry the bucket of water, I feel good. I feel like my movement is increasing.
Thanks. That's a very important point. And I will start asking the faculty. So Aida, Dr. Garcia, do you have any experience with, well, how often when you use this kind of technique to reduce openly a chronic elbow dislocation, how often do you find yourself with an unstable elbow, and do you have to supplement it with either an X-fix or a hinge fixator or a like a pin transfixing the ulnohumeral joint? What's your experience with that? Or you most of the time find that they are stable after the repairs, and then you take care of the wound and then allow them to start arranging them fairly quickly?
Okay. Well, we got two different patients, the ones like he's joined with a good joint cartilage. And we have been done Dr. Anderson technique for the last 2 or 3 weeks, through years. We never get instability after we do all this dissection that is huge. And you may get scared when you see the naked distal humerus. But I think the key of the technique of Dr. Anderson is that you have to create two sleeves, the anterior and posteriors. And when you close that sleeves, you will get enough stability to the movement. Actually, we don't use a splint in the post-op. We let the patient do flexion. We always ask the patient to do it with the shoulder in ADD. So we avoid varus stress. So he can do it really easy, deflection. So for that kind of patient, we have done this technique with good results. I never do transposition of the ulnar nerve, just when I saw excessive nerve tension after the joint reduction, I decide to do the transposition. Otherwise, I will leave it in situ. But in the other hand, when the cartilage is not so good, that happened to me often because I have word trauma patients. I have to do another techniques, and we use an interposition. Interposition, I said, well, arthroplasties, and we use hinge external fixation for that. And we also do the technique with arthrodiastasis, so doing distraction with external fixation to create like a new fibrosis that works like a joint. So depending of the patient, we use different techniques. But we have been done this technique for at least 3 years with really good results without any instability.
Interesting. That's great. And thanks, Aida, for that. And Dr. Harper, there's another question on the chat. I would like to briefly address that as well. You have encountered any difference in HO formation in patients undergoing this procedure with a single posterior incision or dual incisions? And also with that question, I would like to ask you, if you have done this chronic elbow dislocation cases, do you routinely use HO prophylaxis to try to decrease the post-op formation of heterotopic bone?
So the only context in which we see is really chronically dislocated elbows, and I've done a couple, certainly less than Dr. Anderson and O'Driscoll. We see them in sort of a migrant setting where somebody couldn't get care at the border and then sort of arrived. You see a fair bit of that in Massachusetts, and so I've done a handful of these using a 2-incision technique like this. I have anecdotally placed them on indomethacin. I have not sought to do any form of radiation. And we'll probably talk about this later, the only time I begin to think about radiation for prophylaxis is in a recurrent setting, or if there's a lot of HO within the PRUJ, that's when I would do it. The nice part about the prophylaxis is with the indomethacin is that it serves as an anti-inflammatory to help with pain relief as well. So I don't see a tremendous downside to that. And I continue that for 3 weeks post-op.
Thanks. And do you put them on an X-Fix, or do you just protect them with a back?
So I'm in the opposite of a resource limited setting. So I have been fortunate enough to the 4 that I've done like this, I have hinged them, because despite utilizing that 2-incision technique and putting the bone tunnels through, I was not enamored of their stability and max extension. So, having the opportunity or having the ability to put on the hinge, I put on the hinge. Those 4 were in very, very slight women. I'm not sure if that matters. They did not have a lot of musculature, so I'm not sure if that matters at all, but those were the 4 that I did.
So I think we have Sorry, Carlos.
Oh, yeah.
We have a really good question here from Dr. Vamsi, who's one of our faculty from last week. Ligaments are injured and scarred in any neglected dislocation. How can the elbow be stable without ligaments, as this patient has good range of motion? Was it assessed for ligament stability? So I like what Ida mentioned about having them have a shoulder and adduction for motion. But maybe that's a good question for Dr. O'Driscoll and Duane to cover. Are the elbows ever unstable? Is that something that you worry about, that the elbows now have become completely unstable after denuding them? I mean, as Ida just said, when you close these large soft tissue flaps, that should give some stability, because there is soft tissue there that basically is the ligaments and the scar that provides stability to the elbow. But in any cases of these, have you done this procedure and then noted that the elbow is just completely unstable and you have to go back and do more for the patients?
Duane, you want to go ahead first? I can add to it.
I've got an extra case that I'm talk, so that will address it.
Okay, cool. Sean, do you have any comments on that?
Yeah, I didn't quite catch that. It was a little bit garbled. So if the dislocation is a chronic posterior dislocation with the elbow and extension, pardon me, then the triceps is tight. And so when you reduce the elbow, as Duane would say, the triceps becomes your friend, in the sense that as you reduce the elbow and then flex it, the triceps gives a little resistance from behind, which results in joint compressive force, which therefore results in joint concavity compression stability. And so even with no ligaments, if you hold the elbow very gently at its limit of flexion based on triceps limitation, then the joint will be quite stable. So the practice that we've had has been to take the elbow down to an extension point where it does start to feel a little unstable, and limit extension in that first 3 to maybe even 6 weeks, but time isn't, we don't know for sure what the optimum time is. But in the first few weeks, to limit the extension so that it doesn't go down into that range where it could be unstable, because in flexion, it will remain stable. And that obviates the need for any sort of an external fixer device, which have their own complications.
Great, thank you.
Thank you.
Duane, how far, like, when can you get these done closed? That's the question that I'm seeing in the chat. Like, what's the duration in which you think that you can still get this done closed? I know that you see these patients after a long time, so typically that's not something you're thinking about. But like, is it a few weeks that they scar in to the point that you have to do an open reduction? A few months? What's the timeline during which you would still consider trying to do a closed reduction?
We do a closed reduction in the first 2 weeks. And then from 3 to 4 weeks, we do a lateral approach using the technique that we've described, and don't do the medial approach, except for to through elaboration. It's a whole meal.
Duane, we're having trouble hearing you with the signal. Do you mind turning off your camera? Because I think your bandwidth for your internet's a little bit slow, so your voice is coming in a little bit garbled.
All right.
Can you answer that question again?
At 2 weeks, we try a closed reduction. At 3 weeks, we do a limited medial surgery where we release the nerve, and then the full lateral approach that we've described, and we're able to get it at 3 weeks. At 4 weeks, we do the whole medial deal.
Great, very clear. Thank you. Well, I think for the purposes of time, should we move on then to Duane's lecture?
Yeah, let's do that, Kira, and then let's keep the many questions that we have on the chat for the discussion in the next after the next case.
Sounds good. I'll try to chime in as well.
So, Dr. Javaid, do you mind stop sharing your screen, and then Dr. Anderson will share his. Thanks, Shoaib. Dr. Anderson, we cannot see your slides. Well, now we can see it. We can see them now.
Yeah, it's just the internet connection is a little bit slow, I think.
Yeah, that might be the case too.
Can you all hear me?
Yeah, we can hear you perfectly. And we can see your desktop. Do you mind putting it in full screen mode?
Where is it?
Well, Duane, while you pull up your slides, why don't we ask, maybe, Sean, could you answer this question from Dr. Salem Langi in the chat? What would you tell the patient about elbow movement in the presence of developing HO? Too soon to say the surgery is a success if starting to complain of limitation in motion because of HO? Well, how often do you see HO in these cases, I guess, is the question. And
Yeah, I presume that the question refers to after an open reduction of a chronic dislocation. Yeah, I think it would be not unusual to see a little bit of HO that forms. I wouldn't change the rehabilitation based on the appearance of any of the HO. HO is not caused by movement itself, we don't believe. It's possible that HO could be caused or worsened by vigorous, aggressive stretching where there's tearing of tissues, but that's not the purpose after these operations, to tear any tissues. So one should just keep on with the rehabilitation you're doing. The question of whether or not the HO might be shaped or modified in its shape based on the motion is a valid question, meaning that if you don't move the elbow at all, the HO might take on a different shape than if you were to move it and let the HO be modeled a little bit by the moving parts. So we simply keep doing the motion of the elbow, not forcefully, but keep on, and determine at the end of all of that what the range of motion is and whether or not the HO is a problem.
And if it was if it were to become a problem, you can always go back and excise HO and get it moving again.
Exactly right. HO excision is a very predictable operation in the elbow.
Great. Thank you.
And I have a very quick question on that, Dr. Driscoll, before we move to Dr. Anderson
Yes,
talk.
please.
That would you use, if available, tranexamic acid to prevent this in your surgeries or not?
So the good question. We do use tranexamic acid routinely in surgery. It's for control of bleeding. Whether or not it changes HO, I don't know. In patients in whom we think the risk of HO is significant, I routinely use indomethacin, unless they have to have a fracture heal, in which case I do not. Whether or not indomethacin actually decreases HO formation in the elbow has not really been proven one way or the other, but I do use it. So for example, if I take HO out of the elbow, I give the patients indomethacin 25 milligrams 3 times a day for 3 weeks post-op. But yeah, I think that that the medical management or prevention of HO is still yet to be determined. If I could make one little pearl that I think if we fast forward 30 or 50 years, I think this will turn out to be true. So I'll just share it with the group. I think that HO is actually triggered by typically minor trauma to nerves, and they're unmyelinated nerve fibers. So if you keep that in mind, if that is true, then any of the injuries where nerves are injured, even subclinically, or any of the surgeries in which we rough handle a nerve are the ones that are more likely to get HO. And if they've already had a nerve problem, or if they've had HO, then that's a reason to be exquisitely delicate while handling the nerves.
Thanks for that tip. That's very important and yeah, very useful. Thank you.
You're welcome.
Dr. Anderson, do you mind trying again to share your screen? We were able to see it in a second ago. Yeah.
Duane, are you struggling with your slides? Do you want me to pull them up?
Yeah, maybe we could try if you could like pass the slides or.
Yeah. Duane, I'm going to pull up your slides and then you can just talk through them, okay? You want to unmute your mic?
Dr. Anderson, in the meantime, while Kiran puts the slides, so this was the first iteration of your procedures for this type of problem, or what were you modifying it as the cases were presenting? And if you could maybe like guide us through that, through your cases, what have you learned and what have been the most significant game changers to develop this procedure?
Can you all hear me?
Yeah, we can.
Well, I started doing chronic elbows when I came to Ethiopia about 18 years ago, and there wasn't a lot written about it back then, and it didn't make any sense at all to do a posterior approach and take down the triceps. I'm not sure if I ever even did it. It just made no intuitive sense to me at all that would work, because the first thing you want to do is bend the elbow, because the patient is in extension 95% of the time. Why would you even attempt to get a chronic posterior dislocation that's fixed at 10 degrees with 10 degrees of motion? Why would you even think that cutting the triceps is a reasonable idea? So I started thinking about just looking at the anatomy, and it seemed intuitive to me that the way to do it was to basically you have flexors and extensors at the elbow. And so I continued with a posterior approach. And I first presented my experience at the Sign Nail Conference in the Tri-Cities, Washington. And fortunately, Sean O'Driscoll was there. And he said, I used to do posterior incisions, but I found that doing a medial and lateral incision worked better for my patients in terms of hematoma, pain, etc. And I immediately switched after that recommendation and invited Sean to come and teach me more. And so, unfortunately, he's been able to do that and really has enriched all of Ethiopia through his global health initiative in Ethiopia.
That's great. Duane, go ahead and present your slides now, if you don't mind. I can slide through them. Just tell me next slide.
All right. Well, I don't have any disclosures. These are my Ethiopian partners. They're all interested in things other than the elbow, but they're great elbow surgeons, and they have to do these because it would take more than one of us to do it. And my practice is winding down and theirs is winding up. So I have to tell you all that these guys are great elbow surgeons, even though they're not primarily interested in it. Next. And as you can see here, you can see Sean and Rick Papandrea. Sean invited Rick to come shortly after he started coming, and Rick is very enthusiastic about his experience here. Between he and Sean, who was his mentor, they just really created enthusiasm for the elbow and the upper extremity here, not only in Soto, but in all of Ethiopia. So if you want to look at somebody who's into global health, look at those two guys as examples. They're committed to coming here regularly. They're committed to helping the hospital in any way they can. They're great mentors. They're great friends. So Rick is actually being a mentor for one of my senior partners. So that's great. So this is the outline about Ethiopia, cultural practices that influence our practice, the volumes that we do, the pathoanatomy of chronic elbow dislocations, the principles of treating chronic elbow dislocations, and a couple of my mistakes, but at the end, we'll show you it's possible to have great results. So that's the outline. So that's where I live. Can you click again, please? And then again. That's Soto, Ethiopia, southwestern Ethiopia. And we're at 6,800 feet. If you're 6 degrees north of the equator, live where it's high. It's really, really pleasant climate. Next. Okay, so cultural practices have really influenced the number of elbow cases that we do. We have our own term for people who massage and put tight dressings on and manipulate an elbow. We're called Vogeisha here. And so people go to see them before they see any health professional, even if they're educated. So there's frequently a delay in the diagnosis, even for the educated. We frequently operate on chronic dislocations and stiff elbows, and sometimes combinations of both, as you can see here. Next. Okay, so in 2021, we did 24 chronic elbow dislocations. So you can see why it's hard to kind of keep up. Chronic means anything past 6 weeks, but in reality, it's three weeks. We see commonly patients at 3 to 9 months, occasionally 18 to 36, and we did, by our mistake, 1 at 10 years because the patient lied to us. Next. Okay, so this has already been described, and this is a patient for probably 15 years ago. I'm not sure when, but that's the simple sling that we do, is just to tie it, just a simple sling. And then they sit up in the bed and they start flexion exercises 3 days out. And that's another thing that Sean taught me, is that you can don't start moving these at day 1, start moving them at day 3. You get less bleeding. Okay, so get the humerus out, remove the scar around the olecranon. That's really key. The key is making sure that your anatomy around the tip of the ear and the body of the olecranon is not obstructing your concentric reduction. Repair the soft tissues after you've concentrically reduced it to increase its stability, and early motion as determined by intraoperative stability. The key difference in children is you want to preserve the blood supply right down to the epiphysis. And so your dissection has to be more laborious. You preserve the periosteum right to the joint line. And frequently you get fractures of the medial epicondyle that you have to extricate from the joint. Sometimes they're even fused to the articular surface. Next. Okay, so what you need to recognize is that everything shortens. But the triceps shortens greater than the biceps. The ulnar nerve is just waiting for you to injure it. And in our series that we published, we had one temporary nerve injury that totally resolved. But don't leave the nerve in situ if you have a patient that's a real chronic, because you're going to have complete ulnar nerve loss. Okay, the loss of motion leads to stiffness of the muscle unit. And frequently, when you reduce it, your elbow doesn't want to flex to 70 degrees. But as Sean alluded to, the triceps is really your friend. You just have to kind of persuade it to become your friend. Next. Okay, so the ulnar nerve is short. As we already said, we put it underneath the muscle. Next. Okay, so if you get really chronic ones, you have to realize that the bone has not seen a joint reactive force and that the bone does soften. And this is more important in the pediatric patient. I remember maybe a year or so ago assisting a resident, and before I could caution him, he just went, and right before our eyes, and the distal humerus just crushed. It was like a nutcracker. And the triceps is tight. You do increase joint reaction forces when you flex a tight triceps. Be careful. Don't destroy the elbow. And remember that the bone is getting softer. Next slide. Okay, so you have to get the humerus completely out so that you can gain access to it, and so that you can remodel it. And one important point is that as a last step, it's frequently a blind step, and that is you have to cut the dense kind of central posterior adhesions between the coronoid and the humerus. You can't really see it. You got to feel it. Make sure you protect the ulnar nerve, and just cut it with the scissors. Next. Okay, remember also that as time progresses, you've got scar there, and its adherence to the underlying cartilage increases with time. And the orange peel there is to remind me that I have to tell you this story, that this was a long time ago, but I had a pediatric patient, and I was pulling the cartilage. I was pulling scar off the cartilage near its articular margin. And I was just so disheartened to see the whole distal humeral articular surface come with it. It was sitting in my hand, the whole articular surface of the distal humerus. It was like I took the peel off an orange without even trying, and it came off in one piece. I didn't know what else to do, so I just laid it carefully back on there and closed it up. And of course, the patient ended up fusing. So there's a progressive pathoanatomy and pathophysiology that occurs with time. It can be very challenging. Next slide. Okay, so these are what you're looking at in this slide is the key to getting a concentric reduction. There's scar that completely envelops the olecranon. And as you can see here, you have some proliferative synovium attached to the humerus. And you get scar that parallels the margins, both medial and laterally, of the olecranon. Sometimes you have flattening of the coronoid. You have to be very carefully removing the scar from the articular surface, because if you've got 1/8 of an inch of scar that's sitting on the articular cartilage, your X-ray is going to be subluxed. It's not going to be fully engaged. The coronoid can also be flattened and intruding into the coronoid, into the olecranon fossa. So sometimes you have to remove some of that that's been squashed into it. Try to keep as much height as you can, of course, but you want a concentric reduction. That's key. Next slide. Okay, so this, if you remember anything from this talk, it's this slide, is that you got to get the scar that parallels the olecranon fossa. You have some coming up from the sides that are above the depths of the coronoid. It's going to prevent you from completely concentrically reducing it. Your elbow is going to be subluxed. And you look at your postoperative X-ray and you say, how did that happen? Well, that's what happens. I've had to take patients back because I was unhappy with the postoperative X-ray. You know what? You can hope and pray that things are going to get better, but really you need to address that postoperative X-ray, get the best X-rays you can postoperatively. If you have the luxury of getting an intraoperative X-ray, do that. The key is looking critically, remove that soft tissue immediately, make sure that the distal humerus is actually touching concentrically around the distal humerus, that they're kissing one another in a tight embrace. Look laterally, make sure that your radial head is centered over the capitellum and not subluxed posteriorly. Look at all the things that you can to ensure that you are deeply concentrically reduced. It's going to be scar, it's going to be bone, it's going to be this ridge of tissue that parallels the olecranon fossa. Next slide. Okay, sometimes you're going to have this terribly looking distal humerus that doesn't even look like a distal humerus. I wish I had the pointer here, but can you point to where the radial head has been sitting there, Kieran? I don't know if it's you or Carlos that has control.
It's me. You want me to point at the X-ray here? Or are you talking about here?
Right there. That's where the radial head sits. And obviously, the posterior coronoid is deformed. But you don't need a posterior coronoid. You need a distal and anterior coronoid. And obviously, the whole olecranon fossa is completely filled with bone. Okay, you've got a major thing of extra cartilage and bone posteriorly. You got to make it look normal. Okay, sometimes I've had pediatric patients where the medial epicondyle is just fused to that surface, and you're looking at it and you're saying, what is that? Well, it's a child, but it's been so long that the medial epicondyle has been entrapped in the joint and it's now fused.
Is that what this is here, Duane? Is that what we're
looking at? No, that's not what we're seeing there. I don't think it is. I think this is an adult.
Which is very
I think, if you're doing this for the first time and you're a younger surgeon, have a plastic model of the distal humerus in the OR. So you can say, is this the way it looks? Okay, so as you have more and more fractures, there's fractures of the olecranon, etc. The number of fractures increase and the severity of fractures increase. So make that thing as normal as you can. That's, you know, that's what we have to do is, and that's why you have to make it, and why you have to get out rongeurs and osteotomes and whatever, and try to make.
Duane, we're having a bit of a hard time hearing you. You mind turning off your video so we can hear your voice a little clearer? Did we lose Dr. Anderson?
Seems that he's mute. Let me check.
Yeah, when I fell off, it automatically muted me.
Okay, all right. Sorry. Go ahead, Duane. Please continue if you don't mind.
Yeah. Okay. So the X-ray on the left, you can see that there's deformity of the olecranon, and that the space for the distal humerus is not there. And in fact, there's also a deformity of the distal humerus. But you can see the postoperative X-ray that it's better and it's concentric. So in this case, and I've done a couple of these where I've just kind of green sticked the olecranon in the middle of a healed olecranon fracture, leaving a bridge of bone and, of course, as much soft tissue posteriorly as you can, and make sure that you get a concentric reduction. And this patient did well without any further problems. Okay, radial head fractures and non-unions. Again, if you have a radial head fracture, you might be stable in certain positions of supination and pronation. You need to know that on the table so you can protect the patient postoperatively. Next slide. Okay, this is a case that, if we have time, my resident Ebenezer is going to present. This is a challenging case because you know that that is not a good situation. And so that being said, let's just go to the next slide. Okay, when you're starting this, especially if you're operating on a child, the epicondyles may have shifted. Okay, this was an experienced pediatric surgeon that came and injured the radial nerve, the radial artery. Okay, go slowly at the beginning. Make sure you are not cutting through things that you should not be cutting. What I tell my residents is make sure what you're cutting is white. Okay, so if it's red, you're in the wrong plane. You either got to go anterior or posterior. So if you're anterior, it's going to be, the muscle is going to contract kind of anterior obliquely, distally. If it's posterior, be parallel to the distal humerus. It's the triceps. So go slowly. I've been very confused at times. I thought my incision was in the right place, and I had to pull a skin flap posteriorly and reorient myself. Go slowly at the beginning, especially in children. The external anatomy that you palpated may mislead where you make the incision. Be cautious. Next slide. Okay, so you need to balance the triceps and elbow stability. As we already talked about, many of our patients can't get to 70 degrees. So you have the dilemma of stability, which you hope to get in 90 degrees of flexion, versus a triceps avulsion off the tip of the olecranon versus crushing the distal humerus. And so I'm going to change my term here from barbotage to fractional lengthening using an 18 gauge needle. So we try to get the patient intraoperatively to 90 degrees. That's where we feel the most comfortable. If we can get it beyond that, that's even better. We would like to see the patient ideally be about 100 degrees in their postoperative sling. Next. Okay, so this patient illustrates what can happen if you don't have attention to the postoperative position. So this is a 31-year-old female with this X-ray, 10 degrees of motion, normal neurovascular status. Next slide. She had a brachial plexus block. And a few hours after surgery, on her way to the ward, she got this X-ray. So either the sling was removed prior to the X-ray being taken, or she never had one. I'm not sure exactly what happened. It's difficult for people to come forward and say, well, it's my fault. But basically, I had to make a decision. Do I reduce this? Or do I take her back and ensure that the soft tissue repair is done properly and then protect her adequately? Well, I decided to take her back and open this medially and laterally and do a repeat soft tissue repair. So maybe disasters like this don't happen in your institution, but unfortunately, we've seen at least one of these. I can only think of one, but I hope it never happens again. Next. Okay, so this is her at 4 months. Full in the operative, in the clinic notes, it says full motion. So that could mean 10 to 120 with full supination, pronation. God knows what that means. I don't. She had a normal neurovascular exam and didn't return for her scheduled appointment. So either she's very unhappy or very happy. Next.
Duane, do you mind if I just ask a question looking at this X-ray here?
Yeah.
So I see a little hole here. Is that from the soft tissue repairs that you do?
Yep.
Okay. And can you talk about that? Like when you went back in this case and we're looking at the soft tissues, what had happened? Had they torn? Is that why she'd redislocated? What did you see?
I think she redislocated because somebody didn't put a sling on her or took it off to get an X-ray. And with the dislocation and just suture repair of the soft tissues, it's going to tear. And so I think one side was relatively intact and the other side was completely disrupted.
And when you're doing your soft tissue repair, you're using the suture and passing them through little bone tunnels in the lateral and medial epicondyles. Is that what you're doing?
Yes, sir.
Well, thank you.
Okay, a second case I couldn't find. We spent all week as a team looking for this case, just couldn't find it. But on the postoperative X-ray, it was subluxed. And I think you have to be very, very careful about your postoperative X-rays because there can be hints of subluxation. And in this woman's case, this is not her X-rays. This was actually a terrible triad that we had to take back. But this was a woman that I took back the next day because there was subluxation on the X-rays, and it was that scar paralleling the olecranon that prevented her from fully seating. And it was just a lack of attention to detail and ensuring that I was totally convinced it was concentrically completely reduced that made me have to go back the next day. But I think the point here is make sure that your postoperative X-rays are well done. Make sure that you get a concentric adduction. You want to limit your takebacks, and nobody likes doing it, but I just felt like in this case I needed to do it because of I just didn't think I'd have a great result. And since I can't find the chart, I can't give you a final result. But next slide.
Can I ask another question here, Duane, if you don't mind? So walk us through what your thought process is if you're trying to get the joint reduced and you can't get it reduced. What are you looking at? Like what's the order of operations? Where are you first looking for scar? Where are you doing soft tissue releases? What are you thinking?
Well, I look at the olecranon first. I think that's where the key is that you've not narrowed the soft tissue profile of the olecranon at its deepest point. If you take a model of a plastic elbow and you see, well, if the olecranon is too wide and it's too shallow, I mean, you can push till tomorrow and it's not going to reduce. That soft tissue is strong. And you've got to ensure that soft tissue is completely excised. Probably the best way to think about it is you got to make it narrow, medial and laterally, so that you don't have anything obstructing a complete reduction. The other thing that could prevent you is HO around the tip of the olecranon, or a crushed coronoid that's protruding posteriorly. But I think we all would recognize that it's the soft tissues that you think are not going to hurt you that end up injuring you. And I think you need to look at both medial and lateral olecrons. So you have to redislocate. If you're not sure that you're completely subluxed, or you're convinced you're not completely subluxed, just redislocate the elbow and look at the olecranon first. And look at the coronoid and olecranon fossa. Make sure that you don't have osteophytes or HO around the distal humerus that's preventing you. But I would say 95% of the time it's going to be the olecranon in the soft tissue immediately adjacent to its depths.
Thank you.
Okay, so in summary, over prepare if you're going to do this surgery, if you're doing it infrequently, and especially the first time. Know the anatomy backwards and forwards. Have a plastic model in your room. Rehearse the surgery in your mind, or as Dr. Shoaib said, write it down on paper. Look at the view at it many times. I ask God for help before each of these. Call me if you need help. I remember being in trouble, and I knew Rick Papandrea was just getting up for breakfast, and so I called him. I texted him. I said, "Can I talk to you?" And I said, he texted back, "Can you wait 30 minutes?" And I texted back and said, "No." So it was like 4 o'clock my time and 8 o'clock his, or 7 or 6 o'clock his time, but he was able to help me. So if this is going to be your first time, feel free to text me the day before and say, "Can I call you if I get in trouble?" And I'll leave my alerts on. Otherwise, I won't. I don't use a tourniquet unless I can't see. I think patients are happier without it. Start slowly. Find the right interval. Cut on white, not on red. Make sure you're cutting not into muscle. It can be absolutely confusing. Protect the nerve. Get the bony architecture as close to normal as you can by removing scar and extra bone. Get a congruent, deep reduction and confirm it carefully. Motion on day 3. I start motion on day 3 unless they're really unstable, or the patient's an addict, or they're a child. That's my protocol. And I just use a simple sling that they can't take off. It's just tied around the wrist. I think that's the easiest thing to do. It's low tech, but then you're not struggling with a big sling that you have to take off and put back on. And that's our protocol. Okay, so this is a final slide. This is a 21-year-old male, 2 years and 10 months out. At 4-month follow-up, he had a male elbow score of 86, a range of motion of 20 to 100, full pronation and supination. So even at almost 3 years, you can get a reasonable result. Don't give up. I wouldn't try a 10-year-old dislocation, though.
Thank you, Dr. Anderson. That was great, great. I have a question for you. So these patients, when they have been neglected for so long, and sometimes they have very few motion, if any, like 15 to 20 degrees, then you release them. They're very, very happy. Most of the time, I'm assuming they don't come back for a contractor release. So what will be your experience on that? Or can you comment on it? How common is for them to say, okay, I need a contractor, or start asking for more motion or coming back for an elbow contractor release?
Our patients come from all over Ethiopia, and I think it's correlates with one, their level of happiness with the surgery, number one. Two, it correlates with the distance they have to travel. Air flight is increasing in this country, and we're going to have an airport here within 2 years. But there are patients that travel 2 days by public transport because they're poor. And they're, of course, especially if they're poor, they're not going to come back if they're at all satisfied with their results. So I don't think that I can give you any kind of generalization other than what I've just told you. It depends upon level of satisfaction, distance traveled, poverty, or lack thereof.
Okay, and I would like to ask you and the rest of the faculty, do you think this is an operation for everybody? What about like there's some controversies in prior case series in the past, all of them small, about like doing them in the elderly. Like let's say you have a 70, 75-year-old patient with a chronic elbow dislocation. Would you do this operation, the same one, or do you think a Savage procedure is more suitable for them?
Well, I think as a surgeons, we always wanted to do an anatomic reconstruction. We always wanted to put everything in the right place. But chronic elbow dislocation is really tough to manage, right? Because you cannot see the anatomy, you know? So your goal for this surgery must to be functional, must to be that the patient get the hand to the mouse and do the work that they needed. So I think this procedure is really a good option for that kind of patient. I have been trying to do reconstruction. I use a tendon graft and I use the internal brace as augmentation, but the outcome are not that as good as I wanted, you know, for movement. So I think this technique is pretty good. For people older than 65, I think the arthroplasty is also a good option. We have done cases and results are pretty good, but it's an expensive surgery. So it also depends of what you have to work, but always you have to be clear with the expectation of the patient, you know, because movement is not going to be the same never. Well, the goal is function and maybe less pain or not pain after the surgery. So depending of the age of what you have in your hospital, because arthroplasty is also a good option for older people.
Thanks, Aida. I don't, for a lot of countries, for the folks represented on this call, I don't think arthroplasty is really available. So you brought up the concept of like an interposition arthroplasty in some cases. Just for the faculty here, I mean, what's your experience doing interposition arthroplasty? Like in the case that you presented, Duane, where the entire, like that orange peel example you gave, where the entire articular surface came off. Are you thinking about interposition ever? Maybe Duane, Sean, you can answer that question.
John, go ahead.
Sean, you're muted.
Sorry, I was. It's a very good question. Thanks, Karen. I had a strong interest in interposition arthroplasty, and for many years did quite a few of them using a number of different substances, quite a few different substances, and have virtually abandoned them. So it's extremely rare that I would do an interposition arthroplasty now. The reasons for the abandonment came about as a result of the following, maybe 3 factors. One is that when you put in an interposition material, the risk of infection, I think, is higher than when you don't. So deep infections was an ongoing problem with complications. The second, I came to a conclusion over time that was stimulated by a comment that Bob Hotchkiss made to me, that the interposition material probably doesn't matter to the outcome. And I thought it challenging at the time, but there is a superb amount of basic science data from the 50s and early 60s, mainly the 50s from Scandinavia, that shows that interposition tissues vanish from the articular space by within 1 year. And so it's a temporary thing that you put in there. And then the final thing is that I was in a phase 25, 30 years ago of converting from open to arthroscopic surgeries for all stiff elbows, and eventually did them all that way. And I never interposed if I was doing it arthroscopically. And I found that these badly damaged joints that looked like the surfaces needed to be resurfaced did, generally speaking, did just fine without resurfacing them. So I came inadvertently to a conclusion that probably the resurfacing isn't actually a significant enough factor to employ it, except in rare circumstances. So having said that, I'm not a keen fan any longer. I would tell you that if you're going to resurface, you have to be very mindful that if you decorticate the bone, typically those patients have very, very soft trabecular bone underneath that, and you'll end up with something like a neurotrophic or a Charcot joint very quickly. So resurfacing or interposing in an elbow like we saw, I think is not a good idea. And if you don't decorticate and you leave all that bone there, it acts a little bit like Duane talked about when you didn't finish taking all the scar tissue out. The olecranon doesn't quite fit on the trochlea anymore, so it ends up a bit loose. It's not as congruent, and so it's not as stable. That's a long answer to your question, but hopefully it can be helpful.
That was very helpful. Thank you. Carl, any thoughts on the cases that you just saw and the comments that Sean just made?
I'm cheating because when I very, very first started practice, I actually went out to Mayo and was fortunate enough to hang out with Dr. O'Driscoll for a little while. So all the tips and tricks that I have are from him. But I think what Dr. Garcia mentioned is really prescient, is that when you're doing these open approaches, and typically I would recommend going medially and laterally, not posteriorly, you truly cannot see the bone. And it's a very sort of disorienting thing to be a bone surgeon and not be able to recognize where the bone is, because it's truly as though the distal humerus and the olecranon were dipped in wax and then let to dry. It doesn't look like normal bone. And my opinion is to use a 15 blade proximal to the joint to open up that rind, and you can find it. And as you begin to peel it back, it becomes normal, but it will not look normal despite what the x-ray shows you. And you just have to mentally be ready for that.
Mm-hmm.
I thought that there's a really good question in the chat here that I think maybe is worth bringing up. Somebody mentioned somewhere here about doing a shortening of the humerus in a case where they weren't able to get the joint reduced, even with lengthening of the triceps. I guess, it brings up a lot of questions here with these chronic dislocated cases. Maybe that case that this person in the chat is describing was very, very neglected, maybe several years. To get the joint reduced, are you thinking about distraction using an X-fix? Are you thinking about shortening? Like what are different things that you would deal with if you're in the situation where you just can't get this thing reduced at all because you can't get it out to length? Ida, I saw you nodding your head. Did you have a comment about that?
Yeah, we have experience with arthrodiastasis with a hinge external fixation. We do not do interposition arthroplasty. We just do distraction of the joint, and then start immediately the movement with a help of with a good pain control, of course, because otherwise the patient is not going to move. But this is our cases of war trauma. It's a different context because we lose cartilage from the injury. We also have soft tissues injuries. So external fixation is a good option for us for distraction. We do it not just at the elbow, at the hip, at the knee, to restore movement. But shortening, no, I have never done shortening to get a joint reduced. I have done it for example, for a huge soft tissues damage. So I wanted to get close. I do an acute shortening, but not for reduce the joint, never.
If I might comment, in my experiences as I was learning, the most common reason that I ever struggled to reduce a joint or thought that I couldn't was that I had inadequately released the soft tissue off the humerus. Duane made the point, but I think it actually needs to be emphasized once again that unless the joint reduces quite readily, you do need to actually strip the humerus bare. And there's a real temptation to try to keep a little bit of soft tissue on it. Looks like, well, that would be a good piece of tendon, or that almost looks like ligament that hasn't been damaged. I think I'll try to keep that there. But when the elbow has been in a deformed position, and then scar occurs between the two surfaces that are in an abnormal location with respect to each other, you can't then move the parts back to where they came from without that scar stretching acutely, which it doesn't do. And so you end up having to surgically release it. And that's the most important point. Muscles stretch. There's not a problem with stretching muscles. There's only a problem with stretching scar tissue. And so, for example, some of you are familiar with repairing distal biceps tendon. You can have a distal biceps tendon that's been avulsed for a year and put it back in the radius, and the elbow only extends to 95 degrees, say, and 6 weeks later, it'll go all the way out straight because the muscle belly is what's shortened. There's not scarring. The joint isn't scarred. So if you release enough off the humerus to where there's only muscle and nerves and arteries and skin and vessels, then those structures will stretch. And the only concern I would ever have would be, well, am I going to stretch a nerve? And I'm not sure that we know about the risk of nerve stretch injury in reducing these just yet. It doesn't seem to be a common problem, but I guess it could happen.
On the topic of the nerves and the soft tissues, is there a case where you are routinely dissecting out more than just the ulnar nerve, like trying to dissect out the median nerve because of heterotopic bone that you see there? I know that you mentioned that a little bit, Duane, in your lecture, your pre-recorded lecture that we had before this session, that there was a case where you had, found the nerve encased in heterotopic bone anteriorly. Is that ever a problem that you worry about the other nerves other than the ulnar nerve?
I don't remember ever specifically dissecting another nerve out in a chronic elbow dislocation. I've done it for HO in a stiff elbow, but I don't remember doing it in the case of a chronic elbow dislocation. Sean is very astute at reading CT scans of the elbow and telling me where the nerves are. I'm not quite as good as he is yet. Give me another 10 years and maybe I can get there.
Yeah, you can follow the nerves on CT scan quite well, very well. It just takes a little getting used to. The key, two keys are to find the nerves far away from where you're interested in looking at them. So way up high, way down low. Don't worry about identifying the nerve as much as identifying the little bit of fat that's around the nerve. That's what stands out. You don't have to see the nerve itself to know that the nerve is in this area that's about that big. And then the second key is to rapidly scroll through the axial images so this little area of fat moves around as you go down. It's kind of like a motion picture, a series of flip cards. And as you flip them fast enough, it looks like the character is kind of running back and forth and so on. So as you do that, you'll see this moving away from the bone and then over. And then, for example, the radial nerve will move out away. It'll become over the radial head, and then it'll go around, it'll split, and the posterior interosseous nerve will go around the radial neck. And so you can see the nerves very, very well on CT scan, unless there's hardware, or unless the patient had the CT scan taken with the elbow down at the side of the body instead of up overhead. Always make sure you get the CT with the scan up overhead. Very, very important. But nowadays with ultrasound, you can also trace the nerves extremely well with ultrasound. And many of you are probably now skilled with ultrasound. I would suggest that everybody's early in practice should consider ultrasound as important as the internet, probably, quite frankly. Just get very skilled with ultrasound because you can use it for a multitude of things like this.
Thank you. We're coming towards the end of the time here, Carlos. Do you want to, should we just run through a couple of the questions in the chat?
Yeah, sure. I think some of them, one question is like, Dr. Anderson, you have a a very big practice on this for most of the, compared to the rest of the surgeons in the world present in this webinar. Have you seen any, what is the most common long-term complication that you have seen, if any, or most patients are doing fine and they haven't been back? Would you be able to comment on that?
I don't recall a patient ever coming back after you're saying, Dr. Anderson, will you reoperate on me? If I had one, I don't remember it. My practice is winding down here, so in the future, I won't be able to comment on that because I'm going to relocate to the United States. But I think once you get past 3 weeks, your chances of a major complication are over. If you have good follow-up at 3 weeks, I think you're out of the woods except for stiffness. And I think it depends upon the patient's biology, their psychology. I think also, as we've already briefly talked about, is trying to avoid a tourniquet and using TXA. Try to avoid bleeding. And I think all of those things are cumulative and additive. And so try to minimize the risk of stiffness by those attention to details.
Dr. Shoaib, you had a question? You said that you had one in the chat.
Yeah. Now that my patient I've started to see heterotopic ossifications after 8 weeks on his elbow, I would like to ask Dr. Sean and Dr. Anderson, should I go in at some time to excise the heterotopic ossification? And if so, when should I go in? I mean, after 6 months, or do we have a time that I should wait and then go in? Thank you.
Timing has a very clean answer now. Time is at first, there's no reason to wait longer than 6 months. There's no advantage, only disadvantages. Between 3 and 6 months is probably optimal. Prior to 3 months, it's much easier to take out the bone, but the bone is kind of squishy and sticky. So it's actually harder to remove it from the soft tissues. Whereas between 3 and 6 months, you can do what you might call subperiosteal dissection and separate the bone from the soft tissues. So I think of the perfect time as between 3 months and 4 months to take out HO. As for whether or not to take it out, that's dependent entirely on the functional impairment caused by it. So if the patient has a functional impairment, but they've been improving, I would not take it out at 3 months. I'd wait another month or two and see if they keep improving. And if they keep improving, I would just never bother taking out the HO.
Another, just for rapid fire questions here at the end for any faculty who want to jump in. There's a question here also about concomitant olecranon fracture and how to deal with that. I know that's a much longer conversation, but just any tips on that? I mean, are you how do you approach those patients? Chronic elbow dislocation with a displaced olecranon fracture.
I would mobilize the triceps and that olecranon fragment, which gives me quite a bit additional exposure that we didn't have otherwise. You need to mobilize it because otherwise when you fix it and reduce it and fix it and then start motion after surgery, all you're going to do is tear it apart if the triceps is still stuck down. So I would mobilize the fragment. That'll give me quite a bit more exposure and make it easier to find the bones. As we were talking about earlier, when Dr. Harper mentioned, sometimes it's kind of hard to know where the bone is exactly. So, and then I would do the rest of the operation the very same way, and then fix it at the end when you close it.
Awesome. And there are a lot of questions here I see in the chat, and thank you, Ida, for chiming in and answering some of them about the post-op rehabilitation. I like the idea of this very simple low-tech sling with a little cuff and around the neck, and that prevents full extension. When do you let the patient go crazy with extension and go and just do whatever they want? When do you take that sling off?
If they don't have an olecranon fracture, they should start doing active and active assisted overhead supine exercises right away. That actually stabilizes the joint. So it compresses the elbow. Graham King has shown this. It compresses the elbow and holds it stable. So I would be having them doing active overhead exercises somewhere between 100 and 500 times a day. That's just an expression, of course, meaning doing it a lot.
Is that what everybody else does as well? Do you guys allow the I mean, because I think it seems like from Duane's lecture and Dr. Shoaib's lecture, maybe you guys prevent extension for a little while, or at least to a certain degree?
For the first 4 weeks, and then allow the patient to do whatever he wants.
Yeah, prevent passive extension. That's very different, like the arm hanging down at the side or carrying a wallet or a pop can or something. Don't let them do that. So they're in a sling if the arm is at the side. But they can actively extend, but extension can only be active against gravity, not passive.
Mm-hmm.
Very different. Mm-hmm.
Well, we're getting tons more questions here, but I don't think that we can get through all of them.
I won't be able to go through them, Kiran, but like, well, I think we will have to wrap up the session, right? So, well, thanks for the great session, everyone, the faculty and our case presenters. Thanks, Dr. Anderson, for sharing your pathway and developing of this technique and this kind of like very unique epidemiology that not every surgeon encounter every time, but when we encounter this kind of cases, we feel very kind of scared at the beginning, I'm assuming, and thanks for telling us that we can also contact you if we are facing our first chronic elbow dislocation and we need your help as well. I think the key messages to highlight are like these are, despite being uncommon injuries, be careful when you try to reduce them close after 2 weeks. Bad things can happen. Most of the time after 2 weeks, you need to think about doing an open technique. Most of the time, these patients, after using this technique and repairing these two sleeves and repairing the masses transosseously, apparently instability is not an issue, and you can start moving them unless they are like childs or they are unstable intra-op quite or fairly quickly, and most patients are quite happy with the results. Long-term prognosis is to be determined. We don't know yet exactly. Be careful handling the nerve. The nerve apparently can either be, some faculties prefer to put it subcutaneously. Dr. Anderson put it like just into the joint, and no problems apparently have been seen. I don't know if you want to add anything, Kiran, or any of the faculties about it. And yeah, it's been a great session, and thanks for tuning in.
Yeah, closing thoughts from any of the faculty? Carl, Duane, Sean, Ida, Shoaib, any comments?
Well, I would just encourage everyone interested in anything related to global health that the learning experience for me over the past maybe 15 years has been the opportunity to combine somebody with an interest and substantial specialty training in an area, whether that be elbow or something else, with someone who has substantial volume of experience, but without the training, volume of experience with a problem. So it could be something else. It could be chronic perilunate dislocations, or it could be, chronic avulsions with a greater tuberosity, or you name it. But whatever the problem that's common in under-resourced areas is, that is a challenge, that if somebody with a lot of volume of that combines intensely in study and practice and discussion with someone with a lot of experience in the anatomic part, then you can reason together through the issues and come up with hypotheses that you test in each and every case and rapidly develop a method. So this was fascinating when Duane first came to me. I said, well, yeah, I don't have a lot of experience with this, a few, but it's been quite a journey. And so I want to encourage others to try to do that same pairing up of expertise and experience. Thank you.
Thanks. Ida, any closing thoughts?
Yeah, I think this is not a 30-minute surgery. You have to be patient because anatomy is not going to be normal. So you have to be careful not to do more injuries. And I think it's a thanks God it's not a common issue that you find a chronic elbow dislocation, but in places like my country, we still have these cases. And Dr. Anderson gave us a good technical surgery, a good technical surgical technicals to resolve this problem that is not easy. So be careful, go slowly, and then you will get a stable elbow, because I think there's nothing worse than unstable and painful elbow, you know, because the elbow is something that we need for the position of the hand. So patient really needs to move the elbow.
Dr. Shoaib, any final thoughts?
Yeah, thank you very much. I would like to thank everybody, especially the faculty, Dr. Sean, for great thoughts. And my country has a lot of these dislocations, not because people do not have money or they don't have access to the doctors, but because people do not trust surgeons more than these local bone setters. This is because of the lack of training of surgeons and the complications that they have given to the people. People have stopped trusting surgeons and they trust the bone setters more. So this guy had money. He was living in a metropolitan city, but he never went to a doctor until after 6 months. So I also have a case who has a dislocated shoulder for 2.5 years. I don't know if I would be able to reduce it or not. So through this global health and this platform, we are learning a lot, and we intend to make the reputation of the doctors in our country better by helping people.
Thank you. Duane, any last comments?
Thank you.
I just put my email on the chat for anybody who wants it. It was a privilege to participate. Thank you for the great job that you're doing spreading truth throughout the world.
Thank you. Thank you very much. Carlos, you want to take us to the end?
Okay, yeah. Thanks everyone again. Thanks for all the presenters and faculty. It was a wonderful session. We learned a lot. I learned a lot from Dr. Anderson and his experience. And in case, please, it's very important for us that you fill out the post-conference survey. You can take a picture of that QR code, scan it, or you will receive also an email for those of you who have registered to this series of webinars. The certificates will be sent out to those who complete the evaluations of the course for all sessions, and they will be given through email to you. Thanks for joining us today again. We are pleased to have you. We will be very likely, Kiran might confirm that for me, a new series on this on next year. We will be more than happy to receive any question, comments, suggestions for the next series of complex upper extremity trauma next year.
Yeah, Carlos, thanks also for doing such a great job moderating and for your comments. I mean, you know, being a experienced and skilled elbow surgeon yourself, I think your ability to add comments and commentary to this is just amazing. Thank you, everybody. Yes, as described, in 2024, we will be doing more of these conference series. We do complex lower extremity, complex upper extremity, spine, arthroplasty. We're going to do some more peds and oncology as well in the coming year. We're open to topics that are relevant to you. The focus of these conferences is to increase this dialogue between those who work in limited resource settings and those with an interest, but who work in high resource settings, who can share knowledge with one another and experience. I think we have so much to gain from sharing. And honestly, I must say, as a surgeon who focuses primarily on upper extremity trauma, I really do feel that these last 4 sessions have improved. So thank you so much to everybody. Thank you so much for participating. Please do send us your comments and thoughts, and we'll hang out for a few more minutes if anybody has any additional comments. But we'll end the session here. Thank you, everybody.
Thank you very much.
Thank you.